Recording starting. Fine. So we're going to talk about oncological emergencies today, which is the most important thing for you to take away from your oncology week. The person who runs the oncology placement you have in 5th year says that this is what she picks when she writes our exam questions. They don't really test you on like the minutiae of like cancer therapies, but like they will test you on oncological emergencies because this is the stuff you'll have to deal with as an F1 or an F2. In addition to oncological emergencies, some stuff that comes up is a bit about like the side effects of chemotherapy and the side effects of radiotherapy, and we won't be covering that today, but we can go over it some other time maybe. So we'll get started with this case. This is a 54-year-old person with acute onset back pain. So if you have a piece of paper in front of you and just write down what you think the answer is, you can have 40 seconds for this one, which is less than you would have in your SBA, but we want to finish on time. Okay, so before we discuss the answer, so what are we worried about in this patient? What do we think could be going on? So yeah, spinal metastases causing some kind of compression on the spinal cord or the chorda equina. Fine. And based on that, what do we think is the answer? So MRI would be very useful. Giving them dexamethasone would also be very useful. All of these would be very useful, but you would in fact do a rectal examination. If anyone you're concerned about chorda equina in, you need to do like a DRE, and like your counterpoint to that might be, if you're worried about metastatic spinal cord compression, does it matter whether it's chorda equina or whether it's like or it's compression at another level? But the fact is, if you haven't done a DRE, you're not legally covered and you can be sued, and also you're much less likely to get that MRI of their spine. So you would have to do a digital rectal examination. And what is quite useful to talk about when we're worried about chorda equina is kind of the red flags for back pain. Do people want to give me some red flags for chorda equina in particular? So this stuff does come up a lot, and when you do A&E next year, you'll see that anyone with back pain basically they go through the tick list. Do they have any of these red flags? Fecal or urinary incontinence, saddle anesthesia, acute onset. Yeah. Anything else? And then what would you, and on like a digital rectal examination, what are you looking for? Loss of, perianal tone, like this sphincter tone. And there's one other thing about the symptoms that makes you worry about chorda equina. So note our person had symptoms in their left leg. If they had symptoms in both legs, you'd be very, very worried about chorda equina. Some red flags for cancer-related back pain. When would you worry that your back pain is due to cancer? Not your back pain, hopefully, God. Worse at night. Night pain is a red flag just generally, symptoms at night are just generally really concerning. Yeah, absolutely. What else? Thoracic back pain. Yeah, very worrying. Anything else? That's fine. Those are the important ones. But yeah, if they've got weight loss or localized tenderness, and if they've got cancer in their history, these are things to worry about. So in terms of chord compression, it's important to remember it doesn't necessarily have to be chord equina. It can be higher up, and depending on the level, you can get upper motor neuron or lower motor neuron signs. Limb weakness is a common presentation as a sensory loss. And in terms of management, all of those things you saw on the slide were pretty much steps in management. So once you've recognized it, they need high dose of dexamethasone. Often you load them with like 16 milligrams. I doubt they'll ask you the dose for this one because I think it's a bit contentious at the moment. You need to do MRI of the whole spine to look for other mets. Refer them to spinal surgery. And what's like the definitive management of metastatic chord compression? How do you prevent these patients getting worse? Or try and at least. What are the surgeons going to do? There's two options. So yeah, I mean, yeah, you're going to decompress it, so you can do it surgically, and you can remove the met, or you can do it using radiotherapy. You can use targeted radiotherapy. Yeah, exactly. So yeah, that's chord compression. If the chord compression wasn't due to a malignant cause, what single thing on this slide would change? If this was a young person with absolutely no red flags for cancer back pain, and they had like a history of injury, what single thing would you change on this slide? Any idea? Anybody? Budding or just yeah. So you wouldn't do yeah. So you wouldn't do the definitive management is different. I meant in terms of investigations. Sorry, that was a really badly worded question. How would your investigations be different? You wouldn't do any of these things actually. This is only something I learned this week, but it makes sense. How would you change your strategy of investigating the back pain? So if you have a good history that it's a traumatic like disc prolapse or something causing like the compression of the cord, you don't need to do a whole spine MRI. You can just do like lumbar spine or thoracic spine depending on where the back pain is. MRI whole spine is only when you're worried about cancer. I know this because I saw a patient in A&E and I tried to do an MRI whole spine referral, and my consultant was like, why? Because it was like a 23-year-old who probably like had a disc prolapse or something. So yeah, you don't need to do a whole spine if you're not worried about cancer. Fine. What's the sign called? What's the eponymous term? Pemberton sign, and this is a sign of what? Yeah, great. They won't ask you what it's called, but like I like trivia. Yeah, so this is a sign of superior vena cava obstruction. So what are the common causes of superior vena cava obstruction syndrome? So yeah, a space-occupying lesion, specifically things like mediastinal masses. So you can have things like pancreas tumors, lung cancer, other lung cancers that aren't necessarily pancreas tumors, but just metastatic lung cancer. And then lymphoma in the mediastinum is like another big cause. Great. And then don't forget that you can also get it due to a massive thrombus, but like you'd probably know if it was a massive thrombus. Signs we spoke about, Pemberton sign, but you can also get swelling, headache, visual disturbance. And if you look at their JVP, it won't be pulsatile, but like, I'll be honest, if you didn't see a pulsatile JVP, I'd probably just be like, oh, I can't see their JVP. If you can tell, then good on you. Management. Any ideas? It's the same as most of these emergencies. 8 milligrams dexamethasone PO if possible. Okay, so the reason we give steroids is you can reduce the edema around the tumors, and this can reduce compressive symptoms. What if I said this patient had a very, very rapidly growing lymphoma, like Burkitt's lymphoma? What else could you do after giving the steroids? I'm not asking for like a specific treatment, just like a general principle. What could you do for fast-growing lymphomas? Yeah, so if it's a fast-growing lymphoma, you can chemo it. And like the thing is, if it's a fast-growing lymphoma, however fast it grew, it will melt away probably that quickly as well. So you won't need to stent it. If it's a slow-growing tumor, then you need to stent it. So like with lung cancer, you will often need to stent it to prevent it from obstructing the vena cava. But yeah, with fast-growing chemo-responsive lymphomas, you might not need to stent it. You can just treat the underlying cancer. And patients with lymphoma can often, not often, but they can present with SVCO. When I was in 4th year, I saw a case of a patient who presented with this, and they got their dex. They were Pemberton sign positive. They got their dexamethasone. And then they had chemo, and they didn't need stenting. So it is a viable strategy. Right, I need a volunteer, because I bet you haven't presented chest x-rays in a while, because you're like, oh, that's a 4th year topic. Anyone want to volunteer? It's good practice for OSCEs. This could come up.
I'll volunteer. It's been a while, though.
That's great. No, it's fine. Okay, so talk me through this chest x-ray, I guess. There's no patient identifiers because I'm the worst, but
okay,
make up.
Ideally, name, date of birth, etc. This is an. Oh no, it doesn't say AP, so
it does not.
Don't know. This is an X-ray of this patient name, whatever. So if we look at airway, here's trachea her trachea. Let's say his for now. His trachea is central. Actually, no. Let's say her because are there breast shadows? Why am I such a mess? Okay.
It's fine. I wouldn't say there are, but it doesn't matter. Like you'd have a name in an exam, so don't worry.
Okay, fine. So trachea is central, and if we count the ribs, 1, 2, 3, 4, 5, 6, 7, 8. There's 8 ribs, so it's well expanded. Is that the right word? I don't know.
Good inspiratory effort. Yeah, expanded. Yeah, either way.
And then so I don't know if it's an AP or a PA X-ray, so I can't comment on the size of the heart shadow. There's an opacity on the right, medial part of the chest, with not very well defined borders.
Mm-hmm.
And then I'm not sure on the left, is that just a gastric bubble or is that?
Yeah, that's a gastric bubble.
Okay, so let's ignore that. And then I guess his lungs are, I don't know the right word for this, but they're quite black. So I don't know if does that mean they're underexposed, I think?
Yeah, I'd say this is a bit of an underexposed, underpenetrated X-ray.
Oh, penetrated, yeah, that's the word.
Yeah, the quality's not great.
And then I think I've definitely missed stuff out, but I tried.
Yeah. If I had to, so if this patient had Pemberton sign, So, and I had to push you for a diagnosis. What would you go with?
That he's got a superior vena cava obstruction.
Yeah, and what do you think the underlying cause would be based on this chest X-ray? It's fine. Don't worry. Like, just have a guess.
I don't know. I want to say lymphoma, but it's not bilateral, so I'm not sure.
So this is a lymphoma. So yeah, that was really good. So remember, when you're presenting chest X-ray, yeah, do your patient identifiers. What I normally go through at the beginning is exposure. Can you see the entire chest? Can you see both lung fields? Can you see the diaphragms? Can you see the humeral heads? Inspiration, you did, so good inspiratory effort. You count the number of ribs. Penetration, can you see the spinous processes? So there's like, and is it rotated? So if you go through RIPE, you'll go through all of it. And then, yeah, you did A to E, which is exactly what you need to do. Can I convince you with an eye of faith? So that if you look at the top of his heart on the left-hand side, can I convince you that there's some weird opacification there? Like the heart border isn't like a straight line like it normally is. There's a bit of a bump.
Yeah.
So he's actually got lymph nodes on both sides.
Okay.
So yeah, this is mediastinal lymphadenopathy, which could be caused by lymphoma. So yeah, really good.
Can I ask a really quick question?
Absolutely.
About the previous case, if he's got a past medical history of prostate cancer, and you know that, like, if he's got the red flags for Chord equina, if it's not going to change your management, then, like, what's the point of doing a PR exam?
So the reason you do it, he didn't have all of the red flag symptoms. He had a past medical history, had unilateral symptoms, and neurology, except for reflexes, was normal. So it wasn't like 100% Chord equina. If you had bilateral symptoms, then there's an argument to not do it. I think the issue is more also like when you're in A&E, you would have to do a digital rectal examination as part of your Chord equina workup. Otherwise, like you won't get that MRI scan as well, because most hospitals will only have 2 spots a day to like fit someone in for a query Chord equina. So the teams are very, very like there's a very high threshold, annoyingly. So you would need to do a DRE in that case.
Okay, thank you.
Does that make sense?
Yeah, it does.
There's an argument to not do it. It's a really unpleasant thing. Like I wouldn't want to do it either. And like I saw a patient in A&E a few weeks ago, and I was like, do we need to do a DRE? And the consultant was like, yes, you need to do one. Yeah, so yeah, remember this is still stuff that can come up in uroscopy because geriatrics exists and chest X-rays are important. Fine, next case. Again, you have 40 seconds. Right, so which of these are you most concerned? What's going on here? What do we think the diagnosis is? Yeah, so this is Tumorlysis Syndrome. So what would be your answer to this question? Yeah, okay, very good. Would anyone do other stuff first? So the point of this question is remember to stick to like in terms of next step, think about what is the most concerning feature that this person has, and like the fact is this person has a high potassium. Yeah, there's an argument to do fluids first, because they've got because it comes first in an A to E assessment, but the fact is this patient has come in with a high potassium with palpitations, so they need an ECG, and that will determine whether you would treat their high potassium right now and stabilize their myocardium. So we'll go over hyperkalemia management really quickly. So above 5.5 is when you do an ECG. And what are you looking for in the ECG? Total 10 to T waves. Yes, it's been drilled into you. They'd love asking about it though. If it's above 6.5, you don't need to do an ECG, you just treat them. And your treatment revolves around two things, as you probably know by now. So you're going to stabilize the myocardium by giving them calcium gluconate so they don't fall into an arrhythmia, and later you can reduce their potassium by using insulin dextrose, or you can give them salbutamol. So in this patient, the thing you're most concerned about is their high potassium. So Tumorlysis Syndrome is this thing that happens 4 to 7 days after chemotherapy. You get electrolyte disturbance due to large quantities of tumor cells lysing and releasing contents. And remember, when cells break down, the potassium goes up, and alongside the potassium, you also get what else goes up? There's two other things that go up, and there's one thing that goes down. So phosphate goes up, and yeah, you get hyperuricemia. And does anyone know what goes down? Yeah, urate and phosphate go up. Yep. So three things go up, one thing goes down. Calcium down. So remember, calcium won't come to calcium won't come as part of the urea and electrolytes. You'll need to order that separately as part of your bone profile. So phosphate won't come as using as well either. So you'll have to make sure you also order like a bone profile with your urea and electrolytes. And you need one of three other things to diagnose it. Does anyone know what else you need? This patient has one of them, potentially. So you either need a raised creatinine, an arrhythmia, or a seizure to go along with these, and that's how you diagnose it. You don't need a PTH. You may get an AKI. You might not get an AKI though, so it's not reliable, but you do need to raise creatinine. Fine. And management, so what drugs can you use? So if someone's already got tumorlysis, what do you want to do? What's the most important intervention to like make them feel better? One's before drugs, actually. Yes, so hydrate them, so you give them a ton of sodium chloride, yeah. And then you might use a drug, you might not use a drug. Do you know which drug I'm referring to? Yeah, rasburicase, exactly. Allopurinol, so you can, I don't think in the UK we use it, but you can actually use allopurinol to treat it as well. But you tend, what do we normally use allopurinol for in this context here? Yeah, so we use it for gout, but we also use it as prophylaxis of tumor syndrome. So quick revision so what's the mechanism of action for allopurinol? Might as well do some pharmacology while here. It's in the notes, so when I upload the slides, you'll have the answers as well. Xanthine oxidase inhibitor, yeah. And does anyone know what rasburicase is? Yeah, that's allopurinol. Yeah. Does anyone know what rasburicase is? It's slightly different. Yeah, so it's like recombinant urate oxidase. It's actually quite expensive. We don't necessarily use it in every patient, but you can. Effectively, if you think about it, allopurinol is stopping the uric acid from getting really high. Rasburicase is breaking down the uric acid after it's already got high. Fine. Here's another case. So again, you get 30 seconds for this one. Okay, what diagnosis are people worried about? Neutropenic sepsis? Yeah. And what would your answer to this question be? Ooh, it's 2 first, then 3, 3, 2. Anyone else have any answers? Oh, I should send up a Menti. It's more entertaining. I get to see what people go for. 3. Yeah. So this is the one. This is one that's worth talking about. So the correct answer is blood cultures, because you do not want to be treating empirically forever when like sensitivities are very useful. And it would be very awkward if you just continue treating someone with antibiotics and you just didn't grow anything on cultures. So you do want to do blood cultures first, but I'm glad that no one went for number 1, because that's the only like really wrong answer here. You can send off a full blood count after you've done your interventions, but ultimately you need to get some kind of antibiotics in them. But you always need to get some blood cultures and send them off just before you start the antibiotics, in order to because once you give the antibiotics, you won't get a reliable culture from the patient. So what you would do in reality is you put a cannula in, take the blood cultures, and then flush them with IV tazocin using the same cannula that you've just taken your cultures from. So you're doing both things at the same time. The questions like this really annoy me, because like I'm completely aware in real life that you wouldn't just do a single thing, and like but in exams they always want you to do a single thing, but like you have to play the game, unfortunately. So what's a definition of neutropenic sepsis? If you had to define it, how would you say that a patient definitely has neutropenic sepsis? Yeah, so you can't definitively say it's neutropenic sepsis until after a full blood count, but you don't care. You're going to treat it empirically. But yeah, so you've got sepsis with neutropenia where the neutrophils are below 0.5. That's exactly what it is. Fever is above 38, as Claudia said. Like a 37.5 fever, as some people like to class as fever, doesn't count. Yeah, it's 0.5 times 10 to the something. I don't know what it is, but it's 0.5 in the number. And this is super concerning post chemotherapy. So you've taken your blood cultures, you're going to give them IV tazocin. Make sure that they get to hospital, because they're going to have to be nursed in a particular way if they're neutropenic. You want to keep them in a relatively sterile environment. And importantly, you do not wait for any blood results, because they'll die. So just give them antibiotics. Just start your intervention. So this case goes a bit further. So they're still febrile. So hypothetically, they're still febrile 2 days later, and then they're still febrile 4 to 6 days later. What else do you want to be thinking about 2 days after they're febrile? If they're still febrile 2 days after starting tazocin, what might you consider? Okay, so it could be fungal. It's still quite early to think that it's fungal. So the first thing you might think of is, are they sensitive? Is the thing causing the infection still sensitive to whatever you're giving them? So is it sensitive to the to Zosyn? So think about resistance. And yeah, as Vikram said, you want to consider, like, you'd probably give them like meropenem with Vanc at this stage, because very little is resistant to meropenem because we save it for dire situations like this, and Vanc will hit any MRSA. But yeah, it's good to think of cancer progression as well, I guess. Not something I thought about, but I guess like fever is a common feature in cancer as well, so it could just be related to that. Fine. If it's 4 to 6 days, then you're worried about fungal. So you're going to be like, oh, are we treating the right thing? Should we be thinking about fungal infections? And you don't need to know too much about fungal infections during after chemo. It's a bit specialist. I don't really know anything about it either. Fine. Here's some extra stuff with relation to neutropenic sepsis that I think is important. Do you know what you give patients if you're worried that they're going to have neutropenic sepsis to prevent that from happening? So GCSF, you tend not to. So that's used a bit differently. We'll talk about that in a minute. But yeah, Cipro, so like an oral fluoroquinolone, is what you use. Cipro is great because it covers Pseudomonas, unlike any other oral fluoroquinolone. Remember, Cipro is the only oral drug that covers Pseudomonas, which is why it's so important. And then, yeah, some patients might need GCSF if they have neutropenic sepsis, so you can stimulate the white cells being replenished. If they've got really, really severe like infection, you might give them GCSF. When you would give them is not something for you to worry about. That's almost definitely a consultant level decision. GCSF can have some nasty side effects, and it's very, very expensive. What is very relevant to fifth year though is what other drugs can predispose you to getting neutropenic sepsis. So non-chemotherapy agents, what are like the big three you should be worrying about if a patient is on one of these big three drugs? Clozapine, definitely. And what's like the monitoring regimen for clozapine when you start it? This is so clozapine counseling is something you should definitely go over with regard to OSCEs, because clozapine counseling is like a classic OSCE station. Yeah, it's something like that, but you don't need to know the exact thing. But yeah, it's like once a week for the first few months. Then you cut it down to 2 weekly. Yeah, so you need full blood counts very regularly with clozapine because people can die of neutropenic sepsis. And we have specialist clinics where patients on clozapine will go to for that. If any of you were at the Highgate for psychiatry, you will see labels pointing you towards the clozapine clinic. Funnily enough, because we're so good at monitoring clozapine, that's no longer the leading cause of death in patients on clozapine. Does anyone know what the leading cause of death is in patients on clozapine now? I only learned this last week because Ahmed was telling me about it. Yeah, it's like really, really bad constipation leading to perforation. That's the leading cause of death in terms of clozapine complications, which is really sad. Yeah. Two other drugs that can cause neutropenic sepsis via like the same mechanism as clozapine. One is also they're both more for theory, but they can come up with respect to Jerry's. Carbimazole is one of them, yeah. And remind us what you use carbimazole for, because it's a fourth year topic. Sulfasalazine can cause it. It's which is yeah, not the one I was looking for. Yeah, it's used for hyperparathyroidism. Carbamazepine can cause it as well, and I left it off this slide, and it's very important. So yeah, carbamazepine, and then the other one that's very commonly used is like methotrexate. Sulfasalazine tends to be a bit safer than methotrexate. But yeah, the big four. I left off carbamazepine, but yeah, add that to the list, and that's your big four. I'll add it before I send it out. I guess methotrexate is a sellout answer because you can use it for chemo as well. Fine. What's going on in this patient? I'm not sure about allopurinol. It probably can, but I'm not sure if it's that common. I mean, none of them are that common. Let's have a look. Yeah, multiple brain mets. Yeah, this is really sad. Fine. And what's like the management of brain mets? So if you've got, actually, before we go into management, how did patients with brain mets present? Yes, dexamethasone 8 milligrams BD is your first line. So yeah, they might have focal neurology, they might have a raised ICP, but how does that present? So yeah, they might have progressive neurosymptoms. What's more common than that? Drowsiness, headache, yeah. So seizures, that kind of thing. But those are the important things. Yeah, and specifically, I know the things that point towards like a raised ICP headache, like coughing, bending forward, waking up. Yeah, all of that stuff. Really good. Treatment options. Yeah, so you give them 8 milligrams POBD dexamethasone, and it's the same mechanism as ever in order to reduce the swelling. So you'll hopefully lower the ICP a little. What else would you do for this patient? So radiotherapy, yep. And there's two types you can do for this. So you can either do, yeah, treat the primary tumor, whole brain irradiation or stereotactic, where you just target part of it, are both options. You can also do surgery. With someone with this many mets, surgery is off the cards. If you just had like one massive brain met, then surgery is still on the cards. Oh yeah, don't forget anticonvulsants, because like often these patients will present with seizures. Yeah. Someone said toxoplasmosis. So toxoplasma could look like this as well, to be honest. It tends to be multiple ring enhancing lesions, but you'll get a bit more of a history. I just thought you were going to go with brain mets, considering the topic of the presentation. I should have put in toxo just to throw everyone off. Fine. While we're talking about toxo, does anyone know management of toxoplasmosis? T and S. Yes, what does that stand for? You do actually need to know this, even though they're rogue drugs. Yeah, pyrimethamine and sulfadiazine. Yeah. So cotrimoxazole, yeah. So you can use cotrimoxazole. It doesn't tend to work as well in terms of treating it. I think it's a bit more effective at preventing it. So if their CD4 count is really low, you can give them cotrimoxazole, and it can stop them from getting cerebral toxo. And it also will prevent them from getting like a Girovechi pneumonia as well. I can't spell them for the life of me yet. Don't worry, you won't need to. I mean, if you need to prescribe it in an exam, that would be a really mean prescription station, and B, they would give you a BNF, so you could just copy it out. Fine. What's going on here? I'm not going to make you do this one on Oski style. Would you do an MRI before steroids? Yeah. So this is assuming they've been worked up. So they've come in with seizures or whatever. You've done like a CT head. If they've got an active cancer, you'd probably do an MRI head. But yeah, you know that they've got brain mets in this presentation. But yeah, you do need some kind of brain imaging first. Absolutely. What's going on here? What's this presentation? Ooh, SVO or LVO. So What do we look for when we're worried about when we're looking at bowel obstruction? What are the things we look for to determine whether it's small bowel or large bowel? Yeah. So do the lines go across the entire length, or do they stop like halfway through? Is it central or is it peripheral? Okay. So taking those things into account, are people going with large bowel obstruction or small bowel obstruction? One for large? Yeah, so this is large bowel obstruction. There might be a little bit of small bowel obstruction in the back, like as it builds up, if with an not patent ileocecal valve, no, a patent ileocecal valve. If I can convince you, if you look at the left, there's a bit of like small bowel because you've got lines going across the entire width. But yeah, this is predominantly large bowel obstruction. Fine. And in the context, so this is malignant bowel obstruction because we're talking about cancer-related bowel obstruction here. Does anyone want to guess what the best first like intervention we can do for bowel obstruction is? So you treat it as bowel obstruction and you drip and suck them, put them nil by mouth, give them fluids, absolutely. And because this is malignant, what extra thing do we do on top of this in order to reduce the level of the extent of the obstruction? Absolutely, it's always steroids. So yeah, drip and suck, steroids to reduce edema, enemas if you're worried about impaction, but like impaction is probably not like your biggest worry. Your takeaway for oncological emergency is 8 milligrams POBD dexamethasone because it reduces edema around tumors and it works really well. So like almost most of these emergencies, it's a great shout. Fine. And then you'll surgically resect the tumor. And like the last thing to finish on, we're finishing quite early actually. Well, let's talk about hypercalcemia because it's quite relevant to oncology as well. So, why do malignancies cause high calcium? There's 3 mechanisms by which malignancies cause high calcium. Does anyone know them? So there's the big one that everyone usually thinks of, and then there's 2 others. Yeah, so lung cancer can secrete like ectopic PTH. So that's like one of the less common causes. Bone mets is the biggest cause because bone mets tend to cause osteolysis. Multiple myeloma works on a similar way. It causes osteolysis. Yeah, fine. There's one other mechanism by which malignancies can cause high calcium. The clue is it's a similar mechanism to by which sarcoid and sarcoid and TB cause it. So increased vitamin D conversion. So those are like the 3 mechanisms by which you get hypercalcemia in oncology: osteolysis due to bone mets, ectopic PTH secretion, and increased calcitriol, which will convert, which causes increased vitamin D conversion. Fine. And then what's like the management of hypercalcemia? What's like the most important first step? Hydration, yeah, tons and tons of fluid. And then on top of fluid, you can give them bisphosphonates, and I think IV permethrinate is what they go for generally, especially in oncology. But it doesn't really matter, so just give them a bisphosphonate. And yeah, what are the other big causes of high calcium? Just for general medicine, because it can come up again in Jerry's. It's unlikely to, but it's always good to keep an eye out. Hyperparathyroidism, yeah, which ones? You always have to say which ones. when you say hyperparathyroidism? Primary, yeah, is the common one, and then yeah, primary and tertiary, yeah. And you might see a fair few people in geriatrics. You might see a lot of people with high calcium, and like a lot of the time it is cancer, but you'll see people who have it due to like other reasons as well. So yeah, primary and tertiary hyperparathyroidism, malignancy. What else? I know we've done this like a million times, and it's a pain, but it's always good to like revisit things. Two more big causes. Drugs, yeah, so thiazide diuretics in particular. Oh, I already mentioned sarcoid. Yeah, those are the big four. Fine. And then like also things like high vitamin D, like having too much vitamin D. Yeah, vitamin D toxicity, absolutely. Yeah, but like yeah, we've talked about the big four, but like the big ones to remember for year 5, thiazide diuretics and like malignancy are the big ones to remember for year 5. Fine. I think that's everything. Does anyone have any questions? You don't need to know that much for oncology, so don't worry too much. So as I said, if you go through these oncological emergencies and then know some common side effects of chemotherapy agents and some common side effects of radiotherapy, you'll be fine for onc. It's not like huge. You don't need to know that much about specific cancers. There's feedback form. I'll stick around for like a bit if anyone has any questions. It doesn't have to be about this, but any questions at all.